We now have time for a panel discussion, and we welcome any questions or comments from the audience. Please step up to one of the microphones, and I will do my best to see you. And say your name and your question or comment and the name of the speaker who you are addressing. Sir.
Thank you very much for very interesting talks this morning, which I enjoyed it very much. I have a question, some comments to Professor Yonekura for the very interesting presentation of this technology that you have applied. You mentioned some worries about the radiation protection aspects of these methodologies that you are using for the patient, for the area, and also for the radiation workers. I have developed some methodologies recently that we can obtain a lot of information in the depth of the phantom up to the Bragg peak that you have, that we can provide you with the fluence and also the energy, and also for the neutron dose in the beam, outside the beam, for fast and thermal neutrons with very, very high position sensitivity, and also for the workers. I and my PhD students are available to you to cooperate to do this project. Another thing I have to, Dr. Dimitar, you mentioned, very interestingly, the optimization and justification. May I recommend that, of course, I know in USA, in North America, or in other European countries, in Japan and many advanced countries, it is very easy that you do optimization and justification. But many other countries do not have the approaches for the quantification of these methodologies. So may I kindly recommend, if ICIP develops a simple methodology for those who need assistance in this area. I know because I was regional manager and I traveled in lots of the countries, in developing countries, and I know that they know optimization, they know justification, but they do not have methodology for quantification. Thank you very much.
Thank you for your comment. And I would point out that the forthcoming document on DRLs, which will go out for public consultation toward the end of this year, has a section on the practical application of diagnostic reference levels that may be what you're discussing. You'll have to read it and see what you think. Thank you for your comment. Any other comments? Sir?
Thank you very much for the nice talk. I would like to know a little bit about the radiation protection control in diagnostic radiology in Korea. As was mentioned by the honorable speaker, that there is a system of justification, optimization, but as per my point of view, some of the physicians, I mean, the doctors other than the radiologists, they may have sometime difference of opinion, and there is sort of conflict between the radiologist and the physician. Specifically in the general radiology, I'm not talking about the therapy or nuclear medicine. So how practically you guys in Korea control this situation? Thank you.
Thank you for your question. Which one of you would, Dr. Do?
Yeah, thank you for your nice question. And actually, the same problem we met, and in Korean hospitals, every day we are talking about the physicians and radiologists for about the, but actually there is a struggling for ordering and request for medical examinations for radiology department. So every physicians want to eager to have their own procedures with their own knowledge based, but education is very important. So in Korean Society of Radiology, eager to have education material for our colleague physicians, and now we're making clinical decision supporting guidelines, just like IREPER or ACR's appropriate criteria. So after making guidelines, the implementation is very important for us. So other medical societies, such as Korean Medical Association, is another partner for collaborating. So we'll now try to make a course for education and training for our colleague physicians.
Thank you very much. Does that answer your question? Thank you. Sir?
My name is Oleg Belякov. I am a radiation biologist from International Atomic Energy Agency, and I have a question to Dr. Unikura. Thank you very much for your excellent review of light ion therapy. My question is related to the cost of facilities. No doubt, it's very promising and a very good modality of treatment. But proton therapy, and especially carbon ion therapy, is very expensive. Do you think it has future in low and middle income countries? Thank you.
Well, this is a very important point about the cost of procedures, actually. It depends on the initial, instrumentation, actually, part is the most important part, including buildings. At this moment, I think the size of the equipment is still too large to be included in the general practice. It's limited, but there is still research and development going to reduce the total size up to the size where we can put it in the building, in general treatment space, like a 10 meter to 20 meter space, something like that. It is possible in the future, but at this moment, the size is too large. Therefore, it's limited to the certain person, actually. In Japan, there is a trend that it will be approved as an insurance system, but maybe limited on certain disease which cannot be treated by photon radiotherapy, like sarcoma or other bone disease. So at this moment, this is not for general practice.
Just to clarify for those of you in the audience who are not familiar with these installations, a new installation is on the order of several $100 million. So by comparison, a CT scanner is about $1 million, and an advanced interventional fluoroscopy system is perhaps $2 million. So we're talking orders of magnitude more money. Thank you. Next, please.
Andrzej Wojcik, Stockholm University Committee 1. I have a question to Pedro. This was a nice review of the history of ICRP recommendations, but can you say something about the implementation of these recommendations? How good was ICRP in, well, not forcing, but letting the countries implement the recommendations into the legal system? When did this start? Or was it first on a volunteer basis?
Certainly, ICRP provides recommendations, no standards, and therefore they are not mandatory. But of course, as you know, there is a decision in the UN system that the international standards are based, to the extent possible, on the ICRP recommendations. There is a formal statement by the governing bodies of the world, of the United Nations. That means that the recommendations of the ICRP are always in line or translated into standards. And the standards are also not mandatory, but they are taken as a model, as a reference when the national standards are developed. On the impact of the ICRP recommendations, certainly the new, concise, short recommendations have a big impact. I mentioned before, for example, CT, for example. CT was always the manufacturer, were always striving at the best image quality in the shortest time. That was the driving force. And then in the last decade, the manufacturers are actually aiming at achieving CT examination under a millisievert, which is not yet achieved. But certainly, if you were in the Bonn conference a couple of years ago, there were a couple of manufacturers promising that it is a subject that will come in the next year. So there is an impact because there is a concise, focused report addressed to the people who need to read it, and also the others, like interventional procedures, for example. Or the cardiology, you can be pretty sure that cardiologists will read this report, but may not read previous comprehensive reports. So I believe that there is a major impact, not, as I said, not measurable. At the same time, there was an international action plan of the IAEA and the WHO, and obviously these all came together in a synergistic approach. You cannot say everything is ICRP or it's not, but the fact is that this development has raised a tremendous awareness in the world, and the medical professions are now, many medical professions like cardiologists, do they have already a section on radiation protection that didn't exist before? I mean, 20 years ago, 15 years ago, it didn't exist. Now you go into the website and you can see that they are interested in the protection issues.
Thank you. We'll go here and then here.
Yeah, Wolfgang Dörr, University of Vienna. I also have a comment on ion therapy. I mean, you said correctly that the imaging dose is minimal relative to the therapeutic dose. But you also said that the therapeutic dose is highly conformal to the target volume. And the imaging dose is positioned in volumes, in places where there is no target volume, so outside the target volume. And that makes it, I think, even more relevant in comparison to photon therapy.
Yes, that's a good point, actually. The imaging dose is not only a tumor itself, but including surrounding tissues. It's easily going up to close to 100 milligrade, probably. If we repeat the positioning 30 times, 40 times, it depends on how many fractions do you need. So there is a variability. So we should think about that, how much dose we have to give it to the patient. That's true. But comparing with the dose to the gray order, or actually 50 grade, for example, to the tumors, the surrounding area is around 10% probably in total. Even it's very highly conformal. Maybe 2 or 3% is always we cannot avoid. It's less than the conventional X-ray IMRT technique, but still we have to give some dose to the surrounding normal tissue. But definitely it's below the level of threshold, actually, for the tissue reaction. That's my answer.
And I would just mention that that's a concern for normal or conventional radiation oncology procedures as well, and that the imaging that's frequently done immediately before each fraction, so it could be done 30 times, 30 CT scans, 30 cone beam CT scans, all that radiation is not directed just to the tumor, it's directed to normal tissues as well. And 100 milligrade to normal tissues is something that we'd very much like to avoid if at all possible. Sir.
Thank you. My name is Ted Lazo with the OECD Nuclear Energy Agency, and I'll preface this by saying I know nothing about medical radiological protection, so that
Join the club.
But from the context of operational radiation protection, one of the tools that's been extremely useful in managing exposures in occupational settings is dosimetric information. And I know one of Dr. Dementer in particular mentioned dose passports. So my question is, what's the view in general of dose management and dose recording and using dosimetry patient doses as a tool for managing their risks in a certain sense. Is there a governmental approach? Is there a clinical approach with a hospital? Is it part of clinical audits? Is it something that's being considered as important or not? Because in other aspects of radiological protection, understanding what a person's dose is critical to understanding how to manage it.
Did you want to direct that to anybody in particular?
Well, Dr. Dementer mentioned dose passports, but in particular, our Korean colleagues, is there anything in their hospital procedures or in their national regulation and processes that would address that sort of an issue?
Dr. Demeter first, and then perhaps...
Sure. In the Canadian context, nuclear medicine is regulated federally through the Canadian Nuclear Safety Commission, and radiology is regulated provincially through the provincial governments. And I know of no consistent regulation or standard to look at dose profiles across similar fleets of equipment for similar indications, which you'll hear more about diagnostic reference levels later. I suspect it'll feed into that. But so it's done on an ad hoc basis, essentially, and through almost like an audit kind of program, in addition to all of our equipment needing to be seen by a medical physicist and making sure it's working within specifications. But the actual looking at whether 15 CTs operate similarly for similar indications is not legislated or regulated in the Canadian setting. But that's part of the purpose of Canada Safe Imaging, which I showed you, is to try to create some kind of national guideline for healthcare systems to do that.
I guess I was actually talking about individual patient dosimetry on an individual's dose passport.
No, we do not do well. Every patient who's imaged on one of the images on the PAC system is their dose profile, so that is recorded. But we don't do patient dose registries in the Canadian system, and I think they're moving more to a more at the first cut to a more administrative dose profile on the equipment in general versus down to the individual level. Some jurisdictions have moved to individual levels, but not in the Canadian setting.
Yeah, I'll ask the situation of Korea. In Korea, the reporting system of the dose is very much diverse, equipment by equipment. And first, for CT scanning, maybe 50 more percent of the CT scanners automatically generated those report sheets. So, maybe and half of the hospital used those report sheet for control of those recording system, but not yet collected as an individual. I mean that the cumulative dose tracking is not accepted in Korea, but every procedure tracking is very important thing for those tracking. So CT scan is that's so problematic because every new scanners have those report sheet automatically generating. But we have a problem with the fluoroscopy and general radiography machine because even in my hospital, in Asa Medical Center, is a tertiary hospital, but we have some equipment is not revealing those information directly. In that case, Korean FDA and KSR make a lookup table for estimating those for general radiograph or mammography, but it's just estimating, so the gap is very high, and so it's not exact value, but lookup table is very helpful for quality control of each hospital or each clinic. So we are now providing a DAP method for fluoroscopy machine, but it's somewhat expensive for every hospital to have a DAP method. So the hospital's quality control assurance system is now have a problem for that kind of cost problem. And for government regulation, as my lecturer already said that Korean government has two regulation act. One is for a technical aspect of the X-ray machines, include all X-ray machine and MRI, mammography and CT scan. but it's just a technical factor. And for CT scan and mammography scan, we have an inspection system for both the technical factor and the imaging quality factor also. So the ideal thing is every hospital has their own quality control, but some portion, the Korean government has a regulation for those control system, manage those control system now.
Thank you. I would just point out in the United States, as you might expect, it's a very complicated method and a complicated system. Radiation use as part of the practice of medicine is regulated by the individual 50 states, except for mammography, which is regulated by the federal government under the Mammography Quality Standards Act. And the newer CT and radiography equipment and fluoroscopy equipment is all capable of generating radiation dose metrics and exporting them automatically in a format called a radiation dose structured report, or the short version RDSR. And the technology is not yet widely available to accumulate those RDSRs and evaluate them individually. But we need to bear in mind that we do not expect the dose for everybody to be the same for every examination. And I don't want to embarrass you, Dr. Do, but if you'll be kind enough to come up and stand next to me for just a minute. Dr. Do, would you please come over here? Dr. Do and I are each going to go get a CT scan. If we get the same radiation dose, either I'm not getting enough or she's getting too much. Yep. Thank you. Sir.
Yeah, just a question to Dr. Yonekura, and just for the curiosity, heavy ion beam therapy been operating since 1994, right? For more than 20 years. And I heard, it's kind of rumor, but there is no secondary cancer observed. And it's a very interesting question to be asked for the higher rate radiation and its carcinogenicity and so forth. And do you have any intention to have a follow-up of these kind of secondary cancer?
Well, that's an interesting but difficult question to answer, actually. In the conventional radiotherapy, so-called secondary cancer is very specific character, such as sarcoma, very unusual cancer. But the question right now is whether that's such a modern radiotherapy is we are worrying about the effects of low dose, very low dose level radiation in wide range of body, which may cause usual cancer, common cancer. And we cannot discriminate whether it's a secondary cancer or naturally occurring cancer. So we need a large statistical analysis to answer your question, and we don't have enough data, but we are trying to record a follow-up to all patients as much as possible. So that may answer your question in the future.
Thank you. Ma'am?
Next?
Yes.
Yes. Cantone Marie Claire from University of Milano, Italy. My question regards the ion beam radiotherapy, and the question is if you have the chance to use the failure mode and effect analysis as indicated in ICRP 112 regarding the reduction of risk and accidents. And in case, what is your judgment regarding this kind of technique? Because we have a lot of discussion on the utility or not, if this approach, failure mode and effect analysis, depends on the staff, on the specific procedure you use, and so on. Your idea.
Well, you are right, actually. Regarding, we already have a very nice document, previous two documents, which I mentioned in the beginning, that these are very helpful also to this technology. The problem of ion beam radiotherapy itself is that we don't have many experiences about accidental exposure and for travel or something like that. So in the initial step, we should follow the previous lessons learned for prevention of accident. Is that my answer that I...
No.
No,
No,
Your
sorry.
point-
I thought about failure mode and defect analysis that is not retrospective, so it's not based on the lesson learned, but it's a proactive perspective. It's
Yeah.
a different
That's
approach that you mentioned before.
Yes.
Yeah.
The prospective, therefore, the prospective approach is very important to prevent accident. That's true, that which I mentioned earlier. And to do that, we need a step-by-step, pick up the step-by procedures and looking at the possible error and weakness of the one. So we need such a kind of systematic approach. That's true.
But you didn't have experience on this, no.
Yes. Actually, in the publication 127, we list up the all procedure which may be necessary. So
Yeah.
that's the one that we already have,
Yeah.
but not
Yes.
more than that.
Yes, because we did in Pavia with a CNAO center, and yes, but just for the treatment planning, and it was very, very hard and demanding and very complex, and I would like to share with you your experience on this. Okay.
Thank you. Colin?
Colin Martin, medical physicist from the UK on Committee 3. Question is to Dr. Hyang Kun Do. It's about the sort of optimization of the diagnostic procedures, particularly on CT. With the new CT scanners, in particular, the performance and the link between image quality and patient dose, the variation with the different size of the patient is becoming very complex. And so whoever is going to sort of achieve optimization needs to have a detailed sort of understanding of the dose and image quality performance of the equipment. After carrying out dose surveys and, say, comparing results with diagnostic reference levels, who will be undertaking the optimization process so that the dose audit loop can be closed and the doses can be reduced and the procedures optimized?
Yes. Actually, in Korea, in this conference room, there may be Korean medical physicists here, but unfortunately, we don't have much medical physicists for CT, for specialists for CT, those regulations. So at this time, the kind of the act is done by the radiologists and our radiographers. And in hospital base, it is very hard for optimize that kind of protocol with the hospital only. So our society is making guideline and technical standard for the kind for optimization. We provided the material to each hospital, but it's very hard for us. So actually, I show an example. After 2008, in my Korean Thoracic Radiology Society make a technical guideline for CT scan, and I have a research for dose and optimization for before and after the technical standard is establishment, and it's somewhat improving, but it's not so much than expected. So we need to long way to go. But these days, radiologists and radiographers are very much interested with the optimization of the CT protocol. But I'm very sorry for that we don't have much medical physicists, so it's very hard thing for radiologists to do that. Yeah.
Thank you. We're almost out of time. Last question, please.
Okay, last question. Thank you. I'm Mohammad Afzal, a student of King's Sky's Master Program. My question goes to Dr. Hyun again. I would like to ask that in the data shown for the radiology doses in the previous years, you guys are putting a lot of efforts in the design, in the equipments, and education and training. But still, the data of the doses is showing some increasing trend. So can you please explain the logic behind, the reason behind?
That's right. That's why it regards as a justification, because every examination, the dose is somewhat lower and lower, but for a number of the examination, it is very increasing highly. So the total radiation dose of the radiological examination is still increasing now. So that's why we need to establish our own clinical decision supporting guideline for justification and appropriate criteria, because the reducing the number of the CT examination is very important for reducing the radiation dose, but unfortunately, at this time, it's very hard to reduce the number of the CT examination. Actually, it's increasing now. Yeah.
So you're actually increasing the, you're just calculating the cumulative doses, not the dose per person.
Dose per person is, each time the dose is decreasing, but I mean that not cumulative, but the total number of the CT examination is increasing now. Yeah.
Thank you.
Thank you for your question. Dr. Kim and I would again like to express our appreciation to all 5 of our speakers this morning for excellent, excellent jobs. Thank you very much.